the setting up of a pediatric oncology unit in India experience and lessons, with the thought that no child should die of cancer, cure for more and care for all. Without further delay, let me introduce our first speaker, Dr. Vikramjit Kanwar. It's a brief resume. He first did his MBBS long back 1987 from All India Institute of Medical Science. Then he did MRCP from Royal College of Physicians, UK in Pediatrics, Diplomate American Board of Pediatrics, then followed by Diplomate American Board of Pediatrics Hemato-Oncology. He held positions in SHO and registered jobs in National Health Service UK, then followed by Pediatric Resident UCI Irvine, Fellow Pediatric Hemato-Oncology St. Jude Children's Hospital, Memphis. In 2018 to 20, he has a Director in Pediatric Blood Disorder and Cancer Cure Center, Ahmedabad. At present, he is the Chief Pediatric Oncology in our center, MPMMC and HBCH. He has a membership of Indian Academy of Pediatrics, is also with Society of International Pediatric Oncology and member. His professional committees with Chairman of Gujarat Hemato-Oncology Group, Chairman of Neuroblastoma Committee in POG, and co-chaired the SIOP and PODC. Sir, over to you.
Good. I was going to say you could skip over most of that stuff and we'll go ahead and get started as we'll be here a whole day. So, greetings everybody. Is my voice coming through clearly?
Yes, sir. Yes, sir.
Oh, good. Okay. So I can never tell when I'm online, especially with Zoom webinars. These are always interesting. You want me to go ahead and start screen sharing? So let me see. Okay, so if everything has worked, you should be staring at the title slide.
Yes, sir.
Okay, good. So anyway, I was given the mandate of talking about how I set up the unit, which would be kind of disingenuous because the unit was already up and running when I joined in HPCH. But what I can do is give you snippets of my experiences over the last decade or more and tie it in with what will be hopefully a very informative panel discussion where everybody can comment and weigh in on different aspects of care in India, how they've changed over time, how some things remain resource constraints, etc. So, and anyway, we don't need to hand these out since everybody is online. So if it goes too long, they'll simply step away from the thing. So India, you're all familiar with, like, you know, with large population, low per capita GDP. Main thing is we have a large young population. Probably amongst the world's countries, we have the largest population in terms of proportion, under 18 years of age. In my lifetime, I've seen the IMR come down from 100 plus per thousand when I was a medical student to less than 30 per thousand. And the life expectancy go up by decades. But the flip side is now we are able to focus more and more on diseases such as childhood cancer and other childhood genetic conditions, which previously were buried under infection as a covering thing. So childhood cancer in India is about 60,000 new cases per year. It's an approximation because I don't think anybody has an exact number. Part of the challenge is many patients don't make it still to a treatment center. Nevertheless, we have a reasonably good idea as to what the number is. When I talk to colleagues who are non-pediatric oncologists, and I assume not everybody on this conference is going to be pediatric oncologist, they all say, well, your numbers are so small compared to adult oncology. You know, why so much focus? Why so much attention? And the challenge for us is if you look at life years saved in terms of each child treated, you know, the number is huge compared to, say, adult patients. So an adult who's treated, say, in their 50s or 60s, might gain another decade or more of useful life. You treat somebody who is 3 to 5 years of age, and they will subsequently go on to have a long, happy life for, like, hopefully 5 or 6 decades. 5 years survival. Now, this is globally across India. I'm not talking about Tata, which or many other centers now where these have improved over time. The 5 year survival, if you look at government centers, everything else rolled together, is still what I would describe as suboptimal. And again, it's a challenge when we don't have a registry that gives a lot of information or detail. Part of the, we're going to some of the reasons or the difficulties why our 5 year survival rates are not the same as, say, high income countries. Resource constraint is only one of the factors, and resource, we'll talk about that as well. Many cancers are found when the disease is advanced, and many children who are treated may not necessarily reach an oncology center, may be treated by general pediatricians, other individuals, and hence lose their chance to get appropriate treatment. So this survival gap, anybody who's in pediatric oncology has seen this over the years. This is closing, but it has not been eliminated. The World Health Organization has a big push to see if they can empower different countries with different strategies to try and close this. And much of what we're doing at Tata currently is based on that, but was preceded that as well. So I don't want to say it's based on that, but mirrors what is recommended across the globe. As we said, what causes the gap? Partly late presentation of disease. So a lot of patients come to attention often with advanced disease. Lack of knowledge of curability, economic inability to seek care, lack of medical access. The IPPHO, the Indian Academy of Pediatrics, Pediatric Hematology Oncology section, recently has started a campaign to try and improve a referral. Unfortunately, it's limited to some pilot programs. These programs are usually not effective unless they're rolled out across the country or across larger areas. Nevertheless, it is the first step towards what needs to happen. The second is then for patients who do come and actually start treatment, what causes treatment failure? Some patients abandon treatment, death from infection, death from toxicity, recurrence, relapse. So these are all areas where we look at and focus. So I've been going back and forth between the US and India for decades now, simply because my parents were in Delhi when my father was alive. My mother's still there. And I worked with several organizations, including Jeevdaya Foundation. So this was about roughly over a decade ago. And this was the face of pediatric oncology in government hospitals, circa 2007. So typically it was like a 2 to 4 bedded unit where patients got given a chemotherapy. And as far as outside support went, other support, the kind of support you currently see from Impact and other organizations and NGOs within Tata, that was non-existent. So families came or they didn't come, but there was no other external assistance to ensure they kept coming. And the costs of care were borne by the families, not as far as the chemotherapy itself went, but as far as all other supportive care for travel, back and forth, etc. In terms of cases, we could see even back a decade ago that even though the population coverage was similar to my university back in Albany, the number of cases who came in to be treated was roughly a fraction of what we would normally expect to see from a given population area. So we knew there were patients who were not coming in for treatment and were just not reaching an oncology center. And the numbers of cases treated at small government hospitals like this was literally in the dozens rather than the hundreds or the thousands as it is at TMH. And out of those who were being treated, a large proportion of patients at that time were abandoning treatment. So the abandonment rate at that point was like 40+%. Another 15% toxic deaths. And the relapse rate was actually less than that in the United States, only because many patients did not get to that point in their therapy where you could monitor relapse. So abandonment and toxicity were key issues up front. And as abandonment rates have gone down, adaptive protocols are now in more widespread use. We are now having to grapple with the issue of relapse in our patients. The fact that travel time impacts and other external factors impact care seeking has been well known from many centers. This data came from Monica Metzger in almost 2 decades ago. And it's intuitive. If you have to travel a long time, a long distance to get treatment, you're more likely to default as time goes by. So with all this information in front of us, the eventual practice of what we put in place is based on input from a whole variety of different people within the treatment ecosystem. So for example, as physicians, we can look at the protocol, say, okay, this protocol may be too harsh for our patient population. So for example, the LMB 8996 protocols, which are in general use in the United States for B-cell non-Hodgkin's lymphoma, which were being discussed earlier on about an hour or two ago, are not routinely used for patients within India. So Tata will still use the MCP 842, which is a milder protocol, to avoid the toxicity issues you see and the mucositis issues you see with high-dose methotrexate. Similarly, ALL toxic deaths, which this is a slide from Brazil, but all the countries who are like essentially low/middle income face the same issues, and the protocols off the shelf, which we take from the US or UK or Europe, are not always directly applicable. Some are, and some are not. Many of the things which are done to support families are the same across the board, across all countries, whether it's Brazil, whether it's India, whether it's so for example, this could be the St. Jude van if you just change the logo on it. And this could be like, the St. Jude Home Away from Home, which is currently there at Tata. And transportation, sort of meals for families, social workers, community education, all these things are needed to support families undergoing treatment. But at the end of the day, it takes money. And money leveraged not just from local fundraising, but money leveraged from the central government. So within Brazil, the NACC was the local fundraising chapter, but they made sure that they could leverage at least 50% of funds from the government. Currently in India, through various Chief Minister Relief Fund, Prime Minister Relief Fund, Ayushman, we have the ability to leverage a lot of funding which we need for patients and which we're doing right now in Varanasi, but not always as much as we probably could. The costs of chemotherapy definitely have an impact on abandonment rates. And simply because even though the cost may be very low compared to colleagues who look at this from outside the country, but roughly 50% of our population, this was in 2007, earned less than 10,000 rupees per month. Right now the median income in India is about 29,000 rupees per month, if you're interested or curiosity. So making all these changes, putting in place different things to support families, to improve the abandonment rate, does it work? And as in all these things, it depends on what you mean by does and it and work. I'm not going to dwell a lot. We know that Tata has been in place for a long time and treats a huge number of patients, but it has the most collective experience in treating pediatric oncology patients within India today. And I find this side interesting because back in '86, when I was still at AIMS, we would routinely send our patients to Tata for ALL therapy, even though the survival rates in those days were around 40%, because the survival rates at AIMS New Delhi were close to 0%. We had no survivors back in 80 to 86 within the AIMS New Delhi ecosystem. And Tata had already figured out, just based on their experiences, how to support patients and how to use their collective professional experience. So currently at HPCH Varanasi, we now treat, I use we collectively. I joined last October, so really it's my colleagues preceding me plus my supportive SRs and who do a lot of the bulk day-to-day work, like 475 new registrations per year, out of which approximately 350 end up ongoing. You know, about 40 OPD visits per day. Our treatment refusal and abandonment rate is 13.4%. So we'd like to get it under 10%, but it's still fairly decent. 30-day mortality rate is 6.5%, but it's skewed a little bit because tRNA includes patients who refuse treatment, and it's unclear to me how to interpret that metric. This gives the same outcomes in graph format. What we treated, how many patients died, how many patients abandoned, were referred out electively. This gives the breakup of what we're seeing, which is very similar to what I would expect to see for a center this size, except there's some overrepresentation of some solid tumors, and some tumors such as CNS tumors are not being treated actively as much as I would expect to see, simply because we lack a neurosurgeon. So coming close to conclusion, like, if you look at what differences I found moving to India, there are certainly some differences, but the key one I would say is manpower, an ability to dedicate time or allocate time for the variety of things which we would like to do. Nevertheless, and in spite of that, we are able to achieve a lot. There is a need probably for more systemic checks and better organization. That will come with time. Any kind of change implemented needs to be done aggressively in a focused fashion. And above all, you have to keep your sense of humor when you're dealing with so many patients. That's one lesson. So this is usually the kind of meeting I tend to attend, where people are asked, does anybody feel their needs are or are not being met? But so I won't ask the audience that. And I'll simply say in conclusion, India's come a long way. And even though there is some way to go, I'm really proud to be in a small part of that journey. TMH has led the way, put in place modern protocols, and worked with partners to ensure access to care, as have some of the other institutions across India. And there will always be constraints in care. People assume that the US is the land of plenty, but there were constraints there as well. And I'm going to stop because time is a constraint. I've gone about 4 minutes over time, but I'm really looking forward to the panel discussion, which will discuss how these financial and other constraints are met actively within India. Thank you, everyone.
I thank Dr. Vikram.